But we are so happy you are here, and I will turn it over to Dr. Sege.
Great. I am so delighted to be here and be able to present some of the recent data we did. Um, so this is recent health and economic findings. What happens when children are exposed to positive childhood experiences? And we've been working on this for a while, but the data that I'll be discussing today really comes out from this year and last year and really provides much better estimate of what the effects of PCEs are. And as you know, we have quite a bit of experience of what the effects of adverse childhood experiences are. I will not be reviewing that today. That's pretty much out there, and happy to answer questions about it. But now we're looking at the effects of positive childhood experiences, because we know that children can experience both adverse and positive experiences, and many children have both. These slides are compiled from new research conducted by us, and we're at the Institute for Clinical Research and Health Policy Studies at Tufts, Tufts Medical Center and Tufts Medicine. And we've been doing it in consultation and collaboration with wonderful colleagues at the Center for Disease Control and Prevention in Atlanta, and also people from Johns Hopkins and Prevent Child Abuse America in Boston University. So just to know that these results all come from a really wonderful collaboration of people we've been working with for years. So first of all, as everyone knows, just a reminder, particularly if you're new, HOPE is a flexible, strength-based framework that can be incorporated into policies, program design, strategic planning, forms, and internal culture, with the goal of promoting and maintaining access to positive childhood experiences for all children in the community. So the research I'm presenting today is, why do we want to do that? What do positive childhood experiences do for children as they grow up and become adults? The HOPE framework is based on research like what I'm talking about today. It's not all of what we have for HOPE. We've been working on implementation science. Many of you are implementing HOPE. We have people help us do that. And one thing we won't be discussing too much today is we're learning from practice, because we have over 24 organizations that have been implementing HOPE organizationally. We have over 600 facilitators and over 100 champions, many of whom are here today. And one of the beautiful things about where we are now, people talk to us and tell us what works, what doesn't. And so the HOPE framework is constantly evolving. So after today's conversation, I urge you to share this information with your friends and colleagues. Let it simmer. What does it mean for you, for your sector? If are you a psychologist or a doctor or an early childhood educator? Do you live in the Northwest like Amanda, or Northeast like me? And what's your town like? But let that come through. This is not an evidence-based program where we have a 300-page manual that tells you what to do at every moment. This is a framework so you can think big and help the families who participate in our programs, who we care for and about, to lead healthier lives. So with that, hope you enjoy today's webinar. We're going to talk about the epidemiology of PCEs using population surveys. We're going to talk about the effects of PCEs, the implications of our research results, a quick overview of our other recent publications. If you want more information about those, we can do it in Q&A, or we can send you stuff, where we're headed next in research. And then finally, I'm going to turn it back to Amanda, our Director of Training and Technical Assistance, who will talk about resources for translating research like this into practice.
Hear those jets?
So this is the result of a multi-year collaboration with the CDC, the National Center for Injury Prevention and Control. And the first paper we'll be talking about was published in MMWR, Morbidity and Mortality Weekly Report, which my children make fun of the name of it, but it's actually the CDC's flagship publication. So we talked about there was what is the prevalence of positive childhood experiences? This is the largest report of the prevalence of PCEs to date, based on surveys in Kansas, Montana, South Carolina, and Wisconsin. These were added to BRFSS, the Behavioral Risk Factor Surveillance System, which is a state-based phone survey in all 50 states plus the DC. The analyses I'll be showing you today were pooled from all 4 states, and PCE scores were created by summing, adding up affirmative responses to items. And here are the items. Many of you know these, but just as a refresher, there were 7 items on these surveys. As a child up to the age 18, how often did you feel able to talk to your family about feelings, feel your family stood by you during difficult times, enjoy participating in community traditions, feel a sense of belonging in high school, supported by your friends, have at least 2 non-parent adults who took genuine interest in you, and feel safe and protected by an adult in your home. So the way these were scored is for every answer where you said always or almost always on a 5-point Likert type scale, you got that was graded as positive. Otherwise, it was not. So exposure to each of the 7 PCEs varied. About 90% said that they had an adult in the home who made them feel safe and protected. A majority of kids, more than 3/4, felt able to talk to their family about feelings. Fewer felt that they enjoyed community traditions or their family stood by them no matter what. And maybe 2/3 have other adults who took an interest, and happily, most kids felt supported by their friends. Um, Phil's sense of belonging in high school is not as high as we'd wish. And I know in some states, in California in particular, they do statewide surveys to see how that feels. And note, this is not how well you did at high school. It's whether you feel you belong, whether high school, where they care about you, whether it's designed for kids like you, or if you're alienated. So we also looked at the prevalence of PCEs by demographics, and these are adjusted probability ratios. So what that means is in each of these groups, it was normed to one group. They had a 1, so a higher than none 1 meant more likely in that group, and less than 1 meant less likely. So men and women, it looks like the blue are 6 or 7 or high PCEs, red are 0 PCEs. So we normed this to men. There was about no difference between men and women in having high PCEs, and women were more than 1.5 times as likely to report 0 PCEs as men. Looking at states, we normed it on Kansas. I have to ask the statistician why Kansas was normal, but there it is. And you can see there actually wasn't much of a difference between states. Maybe Wisconsin had somewhat fewer people with 0 PCEs, but these are pretty within the way surveys work, pretty indistinguishable. When we looked at race and ethnic group, Asian Americans were a little bit more likely to say they had 0 PCEs, a little less likely to say they had 6 or 7. Black Americans were lower on average at the point estimate of PCE 0 or 6 or 7, but interestingly, within the 95% confidence interval, they were the same as white Americans. The group that really stood out were Hispanic Americans, who were more likely to have 0 PCEs, and multiracial adults who reported that as children, they were more likely to have 0 PCEs. So these are groups that are particularly in need of better access to PCEs.
Hey, Bob, can I stop you for just a second for a quick
Please
question
do.
that I think is relevant
Please.
now?
Thank you.
So Jody, our buddy Jody in Michigan, wants to
Hi, Jody.
know, so is this for the PCE questions, for responses that were sometimes, usually, or always, were those all recorded as having been exposed to the PCE?
No, there was a 5-point scale. So the ones that were positive were almost always or always. And Christy Bethel at Johns Hopkins and the Child and Adolescent Health Measurement Institute did a lot of work to figure out what the best cut point was. And that's what they decided from statistical reasons. Thanks for asking, Jody. It's not on this graph, but I also want to point out that adults who were gay or lesbian or or non-binary also were more likely to have lower PCEs than adults who were cisgendered and straight. And we've no, something to know. Other questions? Amanda, can I go on?
One more question is,
Please.
is there a definition of family from the 7 PCE questions when they reference family? How is that defined?
It's not. It's a beautiful thing. And just anecdotally, I spent a day of my life working with a group of about, I don't know, 15 people from our state health department. And our tasks were to define parent and define family. And at the end of the day, what we decided was a parent is an adult who parents you, and a family is who you think your family is. And we live in a country where I love when we talk with people, the definitions of family are so different. Could be one adult and one kid. It could be a large extended family where there are a bunch of adults, there are aunts, there's grandparents, brothers, sisters, cousins. And so we don't put any definitions on it. It's what people identify as their families. And for me personally, that's been a very enriching experience to see how people define these words. Great questions. Amanda, keep interrupting me. I love it.
I'm personally curious about why sex was normed against men, but we can take that offline and discuss later.
Yeah, things have to be normed against somebody. And my guess, knowing as a CDC, is probably because that's what they did in another study previously. Because they want to make sure that the results we report are comparable to other reports, for example, reports about ACEs. Okay. So now we're going to the new paper that was published this summer, and it was published in JAMA Network Open. And again, you can see a bunch of us from Tufts, Maria Aslam, Cora Peterson, Phyllis Holditch Nylon, and Elizabeth Sweeto from the CDC, Christy Bethel from Johns Hopkins, Jennifer Jones from Prevent Child Abuse America, and Stephanie Ettinger Kuba from the BU School of Public Health. So we had a really wonderful team that was mulling over the results. So this is how the report was organized. We had results from 4 states, again, Kansas, Montana, South Carolina, and Wisconsin. Altogether, there were 20,916 responses, representing a population of 9.25 million people. So if you think that the United States has over 300 million people, this is a small fraction of the American population. And we hope they're representative, but you can't really tell because clearly each state is a little bit different. So the respondents reported the effects of positive childhood experiences on adult outcomes. And there were 2 economists from the CDC, Maria Aslam and Cora Peterson, and they helped estimate the economic consequences of positive childhood experiences. So here's the bottom line. Anybody who has to leave early, I want to make sure you get the answer. Positive childhood experiences promote health across and within demographic groups. So for those of you who are facilitators and champions, and you say PCEs are good, you're saying the right thing. And now we're going to dig into what we mean by this statement. So first of all, and I know that there are a few people here who may have a public health background or interested in this, but one of the questions that always comes up is how do you know people are comparable, that what you're seeing is actually the effects of the thing you're seeing and not the effects of some other factor about those people that you're being fooled by. So Maria Aslam from the CDC did something called propensity score matching, and it makes it seem as if it's a matched case control study. And the way it works is to address group differences that can complicate the interpretation of observational studies. Clearly, no one is randomized to have the right certain number of PCEs. So propensity score matching looks at irrelevant or not necessarily about at other factors that affect both exposure to PCEs and the outcome of interest. So, for example, we did sex before, and men and women may have different exposure to PCEs, and men have more heart disease than women. So you wouldn't want to be comparing women with PCEs to men without them or something like that. So the comparisons are all done in a matched fashion. So comparison between like respondents with and without exposure to PCEs. And if you look at the paper, you'll see what Maria did is she computed the potentially confounding variables separately for each outcome based on the statistical analysis of those outcomes. So a lot of work and thought went into that. It's never possible to completely eliminate bias in a study like this, but this is the most sophisticated approach to understanding how what you're seeing is the effect of exposure and not the effect of some irrelevant thing, something besides the exposure that may be associated with the outcomes. So I'm going to look at PCEs and individual level outcomes. So first of all, higher PCEs lead to better economic outcomes. So again, these are probability ratios. People with high PCEs more likely to have a college education, more likely to be high income. And high income in this survey was defined as a household income of $50,000 or more. And the last one is either one or the other, either high income or college education. So positive childhood experiences correcting for all those confounding variables are likely to help people complete a college education and get paid more. And here's college education broken down. What you like to see in any study like this is what's called a dose response curve. So that 0 PCEs, we can see 40% of a college education, 1 or 2, it looks like it's about half, 3 to 5, it's more, and it's about 2/3 with 6 or 7 PCEs, 67.3%. So this suggests another way to suggest the results are valid because the more your exposure to positive childhood experiences, the more likely you are to have at least some college education. Amanda, keep interrupting me if there are questions. Otherwise, I'm going to keep barreling ahead. Are we good?
We're good. I'll interrupt. Don't worry.
Perfect. I should have known that. Now let's look at physical health outcomes. So higher PCEs are associated with lower rates of chronic conditions. And so there were a bunch of chronic conditions that I'll show you in a minute, but we added them up and you say for each respondent, did they have one or more chronic condition? If they had no PCEs, that was the norm, that was the 1.0. If they had 3 to 5 PCEs, 12%, 1/8 less likely to report any chronic health condition, and 22% less likely if they had high PCEs, 6 or 7 PCEs. So summing up all the different things that people might have that classify as a chronic health condition, PCEs are protective against having at least one of those. Now let's dig in. Heart disease is the most common physical diagnosis or a medical problem or condition in the United States. And you can see the big red one is how many people who have no PCEs report heart disease. If they had 3 to 5 PCEs, 35% less likely to report heart disease. And if they have 6 or 7 PCEs, it reduced the odds almost half. So for anyone who's done survey results, these are really, really large. And you can quibble about what the exact number is. Should it be 47% or maybe it's 40% or 50%? These are large effects. And for those of you who work in this field, you know that these are kind of similar in the size of the effect to what we've seen with the size of the bad effects from ACEs. So very important to understand how powerful these can be. Higher PCEs reduce diabetes, and diabetes is a complex genetic and environmental condition. No PCEs, again, is the standard here. 3 to 5 PCEs, 20% less likely to report diabetes, and 6 or 7 PCEs, high PCEs, 27% less likely to report diabetes. So another common condition, and as you can imagine, diabetes in particular is a little bit of a slow burn. It has a lot of medical expenses, a lot of disability associated with it. Chronic obstructive pulmonary disease, the most common lung disease. And what this shows is of 5 people who might have had COPD, 20% or one of them, their COPD was averted simply by having at least one PCE. So think about that. If anyone knows a person with COPD or has cared for a person with COPD, it's a disabling condition. But having only one PCE can reduce the likelihood of that really, really dramatically. And again, there was a direct relationship with more PCEs, less chance of this disease.
Can I jump in
So
for a second?
sure.
So Karen is curious if it's possible that PCEs are masking other variables that influence economic and health indicators.
We worry about that, and that's why we do the propensity score matching, so that respondents were matched to people who have the same age, gender, other categorizations. And the behavioral risk factor surveillance system asks a lot of questions. And what Maria Aslan did was looked at those questions that affected both the exposure to PCEs and the outcome and tried to correct for that. We still worry about that happening, but to the best of our ability to analyze the statistics, these results are robust. And interestingly, we're really happy to work with the group of the CDC because they use the same kind of analysis for PCEs as they used for ACEs before. So we think it's robust, and that's why I'm not saying this is the exact result. It's exactly 47.2%. I think it's enough to say it has a big effect. Other questions? That was a great question. This is something that's troubled us from the very beginning. We do the best we can with the most sophisticated techniques we have. So this one is, I'm sorry, it's a little bit of a geeky chart, but for those of you who may have seen them, the little dot is the point estimate and the bars are the 95% confidence interval. So 5% or above, or 2.5% or above, 2.5% or below. But these are the estimates of the relative risk for chronic diseases. So arthritis, asthma, cancer, COPD, depression, diabetes, heart disease, overweight and obese, and smoke cigarettes. And the little asterisks, the more asterisks you see down here, the less likely this result was by chance alone. So 1 asterisk is a 5%, and 3, I think, is p.01 or something. Anyway, so there you go. So all of these conditions, and these are the conditions that that are tracked by our public health professionals. So behavioral health outcomes, and I honestly already mentioned depression, 40 to 68% less depression is reported, and a 21 to 36% less smoking. I also want to mention that in Tennessee, they looked at mental health for their own population in the state. They found similar results for depression. And in Montana, they looked for substance abuse of all sorts, illicit substances, alcohol, smoking, and they found similar levels of effect. So this result appears really robust. And I don't think there's anyone in the room who is not familiar with a person, perhaps a friend, perhaps a relative, perhaps ourselves, who struggled with one of these conditions during their life. Very common conditions in the US, and we can be protected through positive childhood experiences. And this one is what we call high PCEs. So this is 6 or 7 PCEs. So sorry for skipping around. We showed you before how even having 1 PCE helped with COPD, and these are the population that had high PCEs. PCEs reduce depression, and again, showing the dose response. If you had 3 to 5 PCEs, 40% less likely to report depression. And if people had high PCEs, 68% less likely to report depression. So that's all about the incidence of disease and conditions. And looks like I'm seeing the numbers on the bottom increase. Are there more questions or people just clapping their hands?
You're good. Just so everybody knows, we are recording this presentation. It will be available after. A PDF of Bob's slides are going to be available. And for our facilitators and our champions, we have slides that you can use on this new research that are going to be unveiled in the hub too.
Okay. So one of the things that we all deal with on a policy level is increasing access to PCEs may cost money. And where does that money come from? How do we justify those expenditures of hard-earned taxpayer dollars, right? So what the CDC did is they used standard economic approaches to estimate the economic value of positive childhood experiences. And this is obviously important for policy. So by preventing disease, positive childhood experiences avert $782,000 per person in lifetime economic burden. So in this graph, you can see that arthritis saves about $20,000 a year, asthma a little bit less, cancer, very, very, very expensive. A lot of money is saved, COPD, depression, diabetes, heart disease, overweight or obese. So these are a function of both how common the disease is and what are the economic consequences. And this little thing just shows how it adds up to 782,000. The diseases here are organized in alphabetical order, not in any other order. So that's what it was per person. And the way those are done is there's the medical care costs, and there are tables about how much it costs to treat a person with cancer, et cetera, or diabetes or whatever. And the other is disability adjusted life years, or how does it affect our health span? And disability adjusted life years are a standard economic measure so that a person who has a disability, there's an economic value to what their disability is. And obviously, if they die early, they have fewer disability adjusted life years. So what you can see is a huge, huge effect on the health of the population, both in terms of lifespan and in terms of disability on inability to enjoy life to its fullest. So that's how this was computed. Again, using methods that are standard among economists. I'm a pediatrician. I read these papers. I love it. But I'll answer as best as I can if there are questions about them. And again, just remember, all these calculations were done using propensity score matching. So people were compared to similar people with different levels of PCE exposure. So you weren't comparing men to women. Women last longer, live longer, have a longer life expectancy. Sadly, Black Americans have a shorter life expectancy than white Americans. So the comparisons were within those groups. So the disability adjusted life years account for those major factors.
All right, can I stop you for a second? We've got a few
Please.
questions.
I was hoping you would.
So let's see here. Does slide 29, so the current slide, mean that the bulk of the cost savings was in DALY?
Yes. Those are called disability adjusted life years. So those are our health and how long we live. Just a really quick example, diabetes is a leading cause of blindness. So if a person becomes blind due to diabetes, but still lives a long time, there's an economic consequence of being blind. So that gets figured into a disability adjusted life year.
So as we can see from this pie chart, the majority of those savings were in those disability adjusted life years.
Yep.
Got it. Great. Thank you. And
Which is
then
important. Yep. Go ahead.
sorry. Let's see here. Is childhood defined at 0 to 18 years old? Intuitively, it seems that these positive experiences in adulthood can impact health outcomes as well, but has research been done to verify that?
No, and I totally agree. And we were talking, I think, Amanda, you were on the call too. We're talking with people from the Office of Resilience in New Jersey, and they're really interested in doing a more systematic look at positive experiences for adults because it seems really likely that these experiences matter forever. You talk about engagement, and adults want to feel we matter and being engaged. And there's a lot of stuff like the Surgeon General came out with how to age in a more healthy way and a thing about loneliness that was among adults. So we think it applies to adults. We haven't studied it yet, and we would love to have partners to look at it with adults. But these studies were thinking back to from the time you were born to when you were 18.
Thank you for clarifying. And I know that we haven't studied it yet, but Rumiana actually popped in the chat a link to positive adult experiences and some research there. So if folks are interested, they can check out that research. And then another question.
Thank
Oh,
you so
sorry.
much for putting that in. I'm looking forward to reading that. Really appreciate it.
These questions coming in. Here we go. Next one. Does the life expectancy for Black people increase based upon educational level, or is that across the board? Is the question.
I don't know all the details of life expectancy. I would assume that education and exposure to environmental toxins, all those things really figure in to the difference in life expectancy among Black and white Americans. The sad thing is that although we're all living a bit longer, the gap between Black and white Americans is still quite large and quite disturbing. And it's not accounted for solely by poverty. It seems like a lot of it is the wear and tear from racism.
Thank you. And then Jessica is curious, to what extent do DALYs reflect the intergenerational dimensions of ACEs and PCEs? And she goes on to say, for example, increased risk of depression due to high ACEs and caregivers with a high ACE background. Could this underestimate the financial impact and effect in that sense?
Yeah, that's a really good point. This is only the respondent themselves and their own experience. And so I'm really glad you mentioned this because each of us, we raise kids. And so those things that we have affect our children. So we know that having an adult with a mental illness is an ACE. So if you're more likely to have mental illness because you didn't have the proper or the didn't have enough positive childhood experiences, that could be an ACE for your child. So I think that we didn't measure that, but that's a really good point that we didn't account for intergenerational transmission. And that seems more complicated analysis, but probably worth thinking about. Okay. I'm looking at you, Amanda. More? Are we ready to go?
Keep on going.
Okay. So overall economic value from these 4 states, 9.4 million people, $216 billion. And that's annually, and that's a lot of money. And if you think that these numbers, that these states are roughly a sample of the United States, it really easily goes into the trillions of dollars in economic consequences. Money saved, economic value happens because of positive childhood experiences. So really important factor. And so we thought a little bit, what are the implications of this? What kind of policies are people already doing that increase access to PCEs? And we just sort of divided this by the building blocks. Family supports, paid family medical leave. When a child is sick or when a baby joins the family, that can be stressful. And it can be economically and interpersonally stressful. Being able to be present and get paid for it is an important setup for positive relationships. The parents who are able to be home when a baby's born, are able to take care of a child or a parent when they're sick and not lose income, seems to be a real setup for the positive childhood experience of solid relationships. Engagement, out of school time activities. And Robert Putnam has written extensively about the dangers of fees associated with out of school time activities, how that excludes some children from those activities and excludes other children from the opportunity to learn about the rest of our wonderful, diverse population, including people who can't afford it. Um, we've worked with school districts around the country. So if a child misbehaves, they can be suspended or expelled. But if you think what a child needs to thrive is engagement with others, and say you take a kid as a football player and they do something wrong, and you kick them off the football team, that may feel good to people who are doing the punishment, but it's likely to lead the child into more trouble because you've cut out one of the really important positive childhood experiences. So we're working with school districts who are figuring out other ways to effectively discipline children so that they don't hurt other kids or do other things that are in violation of school safety or the school rules without excluding them. And that's another trend that's going on. We're really happy to see that. And incidentally, that doesn't actually cost money, except for training and that sort of thing. Environment, safe neighborhoods, access to playgrounds. So safe neighborhoods, we talk about engagement and environment, being able to go out and play and shoot hoops with your friends and not worried about being caught up in violence. Access to high quality playgrounds. And very famously, in Harlem, they began to fix up the playgrounds. They no longer have dirty needles in them, and the neighbors worked to put up murals in the playgrounds, a safe place for kids to play. And all of a sudden, kids went out to play and had a safe environment to live, learn, and play. High quality schools set up an environment that's effective for kids. A lot of the research we have about positive childhood experiences related to the environment come from studies of a positive school environment. And a positive school environment is where a kid feels like they belong, like they've been seen. People know who they are. We saw that in our surveys that if you felt like you belonged at school, and there are a lot of secrets to that, but one of the most important ones is the principal treats the teacher with respect. The teachers treat each other with respect, and they treat the children with respect. And those are kind of the bedrocks of a positive school environment, and they matter. And finally, given what's going on this week, common sense gun laws, it turns out that most Americans, gun owners or not, agree on a set of rules that would make life safer for kids. And without getting into all the politics, having common sense gun laws that reduce the fear of children for being in public or going to school would be important. Emotional growth. This year, we've seen rapid growth in schools that don't allow cell phones in school because they can thwart emotional growth. And there's just a ton of reasons about that. But one of them is that in real life encounters with people is more complex and better than just using a social media. And one of the things that's been pointed out uh, by Haidt in his book about the anxious generation is that in school, you're stuck with those kids. They're going to be with you for a long time. And on social media, you can just ghost someone or snarl at them, whatever you want to do, without any worry that you'll run into them again because you've ghosted them. So it makes you don't have that stake in a relationship. Access to nature. A lot of research shows that access to nature allows children to explore their curiosity, their sense of adventure, maybe even their sense of awe. There are things in the world that are not made by humans. And finally, supporting autonomy. And this is a little more subtle, and it's maybe more directed at parents, that children need a certain amount of stress to thrive. And that kind of stress is striking out in baseball or not doing well on a test. Or, I mean, we're not talking about cutting your arm off or something like that, or constant abuse, but all those stresses. And sometimes we as adults try to protect our children from any kind of badness. And it turns out that having some stress, some successes, and some failures is what gives each of us the confidence to know I've been through that. And here I am, is not the end of the world if that happens. And so supporting childhood autonomy is sort of something that a lot of parenting books now talk about this. These are policies that we think would increase access to positive childhood experiences. None of them cost a lot of money. Some of them cost a little money, and some of them cost no money. But these are policies. And if you think about it, in the last slide, we saw that trillions of dollars of economic value are at stake. So investing in communities to provide access to these positive childhood experiences seems like something that makes so much sense to us. And what we're hoping is that with publications like this and others and your work, um, we'll be able to successfully advocate, whether it's with our city council, our town meeting, the county administration, the state, to really increase access to positive childhood experiences for all kids, because it is so worthwhile, both at a personal level and at an economic level. So with that, I want to switch to other recent publications that we've done. So if you have more questions or more interest, you can find out about them. Health Associations of Positive Childhood Experiences, a scoping review of literature. We reviewed hundreds of papers about positive childhood experiences and report much more depth about the value of positive childhood experiences on improving adult health outcomes. Amanda Nguyen led a paper about reimagining the juvenile justice system through healthy outcomes from positive experiences. And that was recently published, and hopefully we get a lot of uptake. We also looked at the impact of positive and adverse experiences in adolescence. There was, I think those of you who are facilitators may know, there was a longitudinal study of Australian children that showed going forward how those positive experiences in childhood helped young teenagers in academic performance and mental health. This is the companion. There is the longitudinal study of adolescence, and we followed kids from 15 to 24. And we published that recently. And that was led by our colleague, Lynn Kemp at Western Sydney University. Laura Gallant, one of our staff members, wrote a paper on education called The Transformational Impact of Health, which appeared in a publication aimed at educators in a journal called Childhood Education. In their own words, qualitative study of parenting during the COVID-19 pandemic, together with the CDC, Prevent Child Abuse America, and the American Academy of Pediatrics. We ran 3 waves of 6,000 parents about their children. We looked at, and each of those had 2 open-ended questions, and we looked at parents of young children to see what they described in their own words of things that made life during the pandemic better or worse. And short story, this study showed that the Strengthening Families framework really explained a lot of what parents found helpful or not helpful. And this was led by by Tucker Quinn, who was a research assistant with us a few years ago. And amazingly, even after she left us and moved on to greener pastures, she continued working to make sure this got published. And also, based on that same survey, we talked about predictors of corporal punishment during the COVID-19 pandemic. The take-home lesson there is that there is a trend towards reduced use of corporal punishment among all Americans, Black Americans, white Americans, Latinos, men, women, everybody. So that was a wonderful thing. And that's the good side. I always start with the good side, right? The bad side is that parents who said they used corporal punishment with their children, they also had a much higher risk of intimate partner violence because corporal punishment used to be normative. Now it's not. When you find out about it, it's really important to have your antenna up for other kinds of family violence. And that was a new finding from this. We're still working on it. We have a paper now on interactions between PCEs and ACEs. It's going through the CDC's internal clearance process because some of our authors, including the first author, are from the CDC. Those of you who read the newspaper may be aware that there's been a bit of turmoil at CDC, so the clearance process is taking a little longer than we hoped. We're working on an evaluation of HOPE implementation, and this is being led by Amy Myrick. And we have what we call our HOPE innovation networks with a dozen organizations that are using HOPE and developing techniques to evaluate the effect of HOPE on achieving their own missions. We're working with policy people at Boston University to look at the effect of paid family and medical leave on positive childhood experiences. A lot has been written about the effects on child abuse. It reduces child abuse. But now, not only are we looking at its effects on PCEs, but with the help of these brilliant policy people, we're looking at the differences between states. Some states have a longer paid family medical leave. Some states replace a higher amount of your income. Some states do it for everybody. Some states do it only for low income people. So which of those policy choices that have been made, how do they matter? So we're hoping that we'll get that funded. We have applications in with CDC and NIH, and our initial reviews look good. So hoping that happens. Another application in to look at innovations in research and quality improvement. HOPE is hard to study because it's not a program. You don't look at what does doing the thing that's listed on page 17 do for you. So we're working with some really innovative researchers to do this. And all of this is because we want to understand better how local adaptation works, how HOPE can help the many organizations that are using HOPE accomplish their own missions to better the lives of children and families. So Amanda, this is your turn.
Sure. So we threw a lot of different resources at you today. As I mentioned before, we are recording this session that will be available. We also have a PDF of these slides, which you will have access to. All of the research that Dr. Sege mentioned is available on our website. We had thrown the link in the chat, but there's also a QR code here on the left-hand side of your screen if you want to go right into the research. And then specific to this most recent publication about the health and economic impact of PCEs, we created kind of a 10 key takeaways document. QR code on the right will take you there. And Carolina is also popping that in the chat for you to find on our website. The cool thing about this 10 key takeaways is it helps you think about who might care about the 10 key takeaways. In a perfect world, to whatever degree that exists anywhere, we would love for you to be able to use the findings from this study to advocate on multiple levels, right? To advocate for implementing HOPE in your organization, to advocate for policy changes at the local level, at the state level, at the federal level. We want to provide you with the tools that you need to do that. We know that these findings are going to be really interesting to people who care about very specific issues, like folks who care about cancer and diabetes and heart disease, folks who care about the bottom line, right? Budget people. So again, I'd encourage you to take a look at that 10 key takeaways and think about how you might be able to use what you heard here today, put it into your own words to advocate for more equitable access to positive childhood experiences in your community. As always, if you have questions, you can reach out to us directly. I'll pop my email in the chat. I know a lot of you already have it, but our website is a great first stop to look for information. And while I'm
Also want to say, if you don't have questions, but just have stories, share stories with us, because we love hearing stories of how the work we're doing helps you, or if there are gaps you want us to look into. Like I just heard today about the intergenerational thing, which I think is really important, something for us to think about. But if you have success stories, it makes us so happy, and we share them with